Hello, everybody. This is Joe Firestone for Empowering Democracy. I hope you're doing well this Black Friday morning. Of course, Black Friday is not simply a morning now, it seems to be a whole week or more. But there we are. We can do little about that in the short term. Hello, Steve. Steve says a day off today. Laugh out loud. Yep. Yes, a day when you can watch all the shows that you would like. Well, today, our Empowering Democracy show is about hospital billing and is entitled Hospital Billing is a Crime. Uh, that's not quite the same thing as the title of the article that inspires this show, or at least partly inspires the show. That is called Hospital Billing is a Crime Against American Patients. So, this is about hospital billing in America. There's Kay. Hi, Kay. And Dolores. Hello, Dolores. I guess I first had an experience with hospital billing back in it must have been 1993 or so. Okay, Bonnie and I had an interruption of our health insurance at that time. Uh, our Kaiser health insurance had gotten too expensive for us. We hadn't reached 65 yet, and we didn't have any Medicare. I was in the consulting business, which uh, sometimes is pretty good, and as they say, sometimes it's famine. So it's feast or famine. We were in a famine period, and the insurance costs had risen. The premiums had risen to $750 a month for a family, and that was just too much to pay. So for a couple of years, we gambled. One of the things that went wrong is we went out for dinner one night to a sort of Japanese Korean restaurant, which was a pretty good restaurant. But Bonnie took a dessert there. That simply didn't agree with her. And we had to run over to the local hospital in Northern Virginia to find out what was wrong. So we went to the emergency room, sat there for a while, and then she was taken in. Well, of course, as soon as we entered the emergency room, we were sent um, uh, to a place where they could collect payment in advance. And we had a credit card, so we forked over our credit card, and they took $250. And we figured that would be the cost. That would be all the cost. They wanted to get paid in advance, so why wouldn't they take enough to be paid in advance? But that wasn't the way they were operating. And so she was treated. It wasn't very serious. Okay, it was an allergy to something she'd eaten, okay, at the restaurant. And so we were treated that day, and we didn't think anything of it. And of course, about a month or two later, we receive a bill for something like $1,125. Of course, I hit the ceiling. I looked over the bill, and some of the codes were incomprehensible to me. I had no idea what they were talking about, and there were also other charges on there that didn't seem to correspond to any reality we'd experienced at the hospital. So we sent them a certified letter objecting to the billing. Uh, they in turn turned us over to a collection agency. As we were billed by the collection agency, we sent them certified letters citing the legislation that was current at the time and pointing out that we were perfectly willing to pay the bill if they could justify the billed items, okay, and the codes on there. There followed a series of communications about this with the collection agency. Finally, we said to the collection agency, we don't want to hear from you again. This is between us and the hospital. Get out of our face. Okay. So this ended up in court. About a year and a half later, they sent us a summons, and we went to the courthouse in Alexandria, Virginia, where we lived, to challenge them in court. So we were all ready, and about 15 minutes before we were due to walk in, there's an announcement on the loudspeaker saying that the following people should collect in a corner of a very big room to meet with a representative of the hospital. And we were one of the names, okay, that were mentioned. So the lawyer then informed us that they were going to dismiss the complaint with prejudice, which meant, of course, that they could bring up the complaint again sometime in the future. But the fact was, they didn't have the evidence to back up their bill that they could give to the lawyer. So ultimately, they couldn't go into the courtroom and win that case, and they knew it. They had to come with documentation of all the charges that was different from the documentation present in that very mysterious bill that they sent us, with billing codes that no one could know. In other words, no regular people could know the billing codes, know exactly what they were billing for, and be in a position to either say yes to it or say no to it. So they dismissed the whole case with prejudice. We never heard from them again. So we actually won that court case. It's now something like, I don't know, 25 to 30 years later. So I don't think they can bring up the complaint again. If they do, I have no idea how they could possibly document it. They couldn't even document it a year later. So certainly they wouldn't be able to document it. So that was my experience with hospital billing. The amount of it was outrageous and did not correspond to the services we received. Steve Wolfbrand says, I went many years with no insurance when I was young. Most of us did back then. Yeah, we generally always had insurance, uh, from our jobs. And the main thing that happened on this occasion is that I was working as a consultant. There are no fringe benefits, of course, for consultants. You have to pay for it out of what you get. Uh, and in our case, of course, the consulting had dried up for a while. And there was no way we could pay $750 a month for the Kaiser insurance, gotten on the open market. Now, as soon as we reached 65, okay, which occurred a couple of years later, we would have been able to pay for it, but at that time we just had to take a chance. And this emergency call at the hospital is just one instance in which we lost. There was another instance in which the gamble lost also. I evidently broke a small bone in my foot, though I never found out whether this was the case. And so I was hobbling around for a while, but after the emergency room experience, I didn't dare go back to the hospital. I would have come out broke. So the little bone in my foot healed after a period of time, and now it's completely normal, of course, never gives me any trouble. But certainly, if we had a Medicare for All program, I would have gone in and, easily taken care of it. It wouldn't have been a problem. Anyway, as soon as we got, on Medicare, we were able to join Kaiser again, and we've been able to maintain that insurance ever since that time. And so our health care has been good and has not broken our bank. Kay says, we had none when my Scott got sick and he died at age 62. That's terrible. Terrible. See, he says, same thing happened to me, Joe. Hernia operation. Even with insurance, I was getting bills from many actors, the hospital, the surgeon, the anesthesiologist, well, whatever, and others. Yeah, I was getting those bills too. Okay, they were coming through the hospital, though. It seemed the hospital was collecting for everybody involved. They claimed to have sent in a doctor to treat Bonnie, but we were sure we never saw anybody except a physician's assistant. That was one of the reasons why we were contesting the bill. She was very easily treated with Benadryl given intravenously. They, of course, were charging a fortune for that. They got our $250 that time, but that's all they got out of us. So D from Around the World with Brandy and D says, hi, Stephen K. K says, hi, D, Steve. Steve Wolfman says, Joe, sounded like you cooked quite a meal. I don't even know what a risotto is. Okay, a risotto is a particular form of rice It takes a special rice, arboreal rice, okay, is what it's called. Okay, and the way you cook it is by gradually adding liquid to the rice. In other words, there are other things you do that to start it off. But when it gets done, after absorbing very slowly all of the liquid, that you use to cook it, okay, after basically stir frying it uh, at the start to get by the shell on that particular kind of rice, and after adding various things to flavor it and supplement it, uh, it can be very delicious. First time I ate a risotto, I was actually pretty old by then. I was somewhere. Yeah, I guess I was in my 60s. I was giving a presentation at a meeting on portals, enterprise portals, and I went to Chicago uh, for that particular meeting. And one night, I went to a restaurant where they were serving risotto, and I never tried it. Okay, this was a simpler risotto than I made yesterday, but it was really a revelation. It was so delicious. Uh, so I decided to learn how to make it, and I've been making it ever since. So Steve says, Joe, sounded like you cooked quite a meal. I don't even know what a risotto is. So that's basically what it is. You add the liquid in stages to the rice, and you keep stirring, okay, continuously, and the liquid gets gradually absorbed. Usually, it's absorbed that way, in 3 rounds of adding liquid, okay, and absorbing it. But on Saturday night, I'm sorry, but last night, I must have done it in 5 rounds. I was adding the liquid so slowly and continuously stirring, which is annoying, but the result is really worth it. Okay, really worth it. I had those mushrooms in the thing, and the green onions, and I added some peas at the end, and of course I had the saffron in it. That was really delicious. And Steve says, Doc. Steve, sometimes you call me Joe, sometimes you call me Doc. I don't know why. Doc, with my nasty habits, I have no right to be alive, and yet I'm healthy as a horse, the doctors say. Some sort of miracle, some sort of a miracle. Uh, Many of my friends did not make it. Yeah, some people are very lucky. They never get sick. They remain as healthy as a horse, okay, until the day they die. And sometimes the day they die is quite advanced. So far, you've been very lucky. You must have very good genes. Bonnie and I have been pretty healthy too over the years. Yeah, pretty healthy. The only thing I have that's wrong with me is the prostate cancer, but I've had that for more than 10 years now. Okay, I expect something else is going to kill me first. Steve Wolfbrand says, maybe I'm related to Keith Richards. Okay. Kate says, I worked in healthcare when it was not for profit, and I don't trust it now. Yeah, it's very hard to trust it because it's so instilled with the profit motive. It seems to be profits overall now, okay, which is no good, of course. But anyway, I have shared a piece with you that I want to go over because it's so striking. This piece uh, was by Robert Kuttner, who used to be, for years and years, the editor of the American Prospect. So I guess about a year and a half ago, he decided to semi-retire. And he was succeeded by Dave Dayen, who has been a wonderful choice. Just a wonderful choice. If you read the prospect and you read both the articles by Dave and also his attraction of other people to the publication, for example, Ryan Cooper, Alexander Salmon, Dave Dayen himself, of course. There's Kuttner, okay, and Harold Meyerson. Harold Meyerson is primarily, a labor writer of note, who was also a columnist for the Washington Post at one time. Writing about the labor beat. It's quite a lineup, of columnists, and of course they occasionally have other people writing for them too. But those five people are kind of the heart of it. It's hard to find a better lineup in any of the other Washington types, of publications. It's certainly a Washington-centric publication, but one doesn't have to live in Washington to be running the publication. For example, Dave Dayen, his home base is in Los Angeles, not in Washington. Anyway, hospital billing is a crime against Americans. So Bob Kuttner was in Europe, and he happened to go to a hospital when he was there. This, though, is the picture of Massachusetts General and Brigham Young. Those two very good hospitals merged some time ago, and constituted themselves within the Partners Healthcare Company, which is an umbrella company that does them both. I not only know them generally speaking, but I also wrote an article a few years ago, and I wrote a book as well that contained a case study of something they did in terms of the hospital to cut back on medical errors. They installed a particular kind of computer system to do that. I was working in the knowledge management field at that time, and in order to illustrate a particular approach to knowledge management, I and also my co-author and my partner at that time were using Partners Healthcare as a case study to illustrate a particular approach to knowledge management. I've also had some of the Partners Healthcare people in the knowledge management training classes that I used to teach with my partner, Mark McElroy, who was also my co-author. Anyway, Paris, last month, I experienced some symptoms that mimicked a possible heart attack. Turned out to be a false alarm, and I'm fine. I've had that happen to me too. I've had it happening to me twice. Both times it was due to stress situations, working too hard. But taking no chances, we headed for the emergency department at the American Hospital of Paris, where I've been living this fall. Tough duty, right? Living in Paris this fall. I got a complete workup, a full physical cardiogram, also blood tests, a scan to check for possible clots, and a consultation with doctors. The care was efficient and superb. It all took less than 4 hours. At the end of the visit, when I was pronounced in good health, I was presented with the bill. 875.57 euros, or about $890 at the prevailing exchange rates. At a good hospital in the United States, the bill would have been at least $10,000, maybe double that, mostly paid by insurance. The visit to the ER alone before a single test was done or care was provided would have been billed at more than the total cost of my workup in France. In the US, the average ER facility charge is $1,201. Now, in my case, during the 90s, there wasn't a facility charge on the bill. That wasn't a separate line item. Very interesting. My visit was such a bargain compared with standard billing practice at U.S. hospitals that I wondered if I was somehow being subsidized by the French medical system. So I sought out one of France's leading experts on hospital financing and comparative hospital systems, Dr. Isabelle Durand Zaleski, who was both a professor at the University of Paris and a practicing physician. Dr. Durand Zaleski reviewed my bill, which was conveniently displayed in a single page with clear line items, I guess no codes. She confirmed that these were the hospital's actual costs, and the identical bill would have been sent to the French Social Security system had I been a French citizen and and also bien sûr, the French citizen would have paid nothing out of pocket. How are American hospitals able to bill at 10 or 20 times these rates? How does their billing strategy interact with the near collapse of the American hospital system? There are several parts of the answer. One is that there is no direct price regulation in the United States. So hospitals are free to charge what they think the market will bear. The market in this case is mostly insurance companies. Hospitals have been on an orgy of mergers and acquisitions to increase market concentration and bargaining power relative to insurance companies. In Boston, where mergers have reduced hospitals to two large systems, the big hospitals tell the insurers, if you want your subscribers to be able to use Mass General or Beth Israel, you have to pay our charges. So the hospitals control the insurance industry there. This is partly in reaction to health insurance industry consolidation across America. Concentration on one side of the transaction begets concentration on the other side. My colleague David Dayen has called this concentration creep, quote unquote. I like that, concentration creep. They're all concentration creeps. Most hospitals in the U.S. are either for-profits or nominal nonprofits, like large teaching hospitals that behave just like for-profits. Their goal is to maximize market share, particularly for the most lucrative specialized procedures. That means they spend a great deal of capital, not just on acquisitions, but on construction of new facilities that may be redundant in many cities and on new costly equipment. As we've seen, a French hospital bills actual costs. By contrast, a French hospital bills actual costs. That was the right emphasis on it. By contrast, an American hospital adds to the bill several layers of overhead, even with exorbitant markups. The capital cost of a merger is part of your bill, along with the capital cost of the equipment. For instance, in the United States, when you get a scan, you are being billed for part of the capital cost of the scanner, plus the hospital's markup. In France, you pay a flat rate that has been already negotiated with French Social Security based on how long you were in the room, any materials such as injectable dyes, and the salary of the technician. My scan was billed at 280 euros. Yes, that's roughly $300. In the US, the average price of an inpatient CT scan is $4,750. Okay, I was in a hospital where I got actually a few CT scans. Okay, I was there because, and we had, of course, our Kaiser coverage by this time. Okay, I was there because I bumped my head when getting out of my car. It was a pretty severe hit. And a couple of days later, I wasn't walking properly. And so, okay, I checked into the hospital, okay, at Kaiser, not in Alexandria this time, but a different hospital. Uh, I had a subdural hematoma. So the total bill for that, including follow-up meetings and everything else, okay, they had to do some surgery on my brain. So this was a case of brain surgery to put a stop to the bleeding in the hematoma. Now, the bill for all that was something in the neighborhood of, I forget, $60,000, $65,000. I would have been absolutely bankrupt with that. The total Kaiser charge for that treatment and all the follow-ups, drugs, okay, everything else. I must have had 3 different scans during that period of time. It was $100 because I had Medicare and I had the Kaiser supplement, okay, to it. And all those charges were covered with the exception of $100. Well, that included all the rehab too. I had some rehab at home for that. My Brandeis colleague, Professor Stuart Altman, a national expert on hospital costs, who was the longtime chair of the Massachusetts Health Policy Commission, the state agency tasked with restraining costs, calculates that at more than $6,000 per patient, the U.S. hospitals have triple the capital costs of Europe's hospitals. Meanwhile, every major European nation not only spends far less on healthcare, but has much better outcomes in terms of every major health indicator. The more complex the billing strategy is, the more it adds to costs. Expenses related to billing add about $99,000 per year per clinician, or about 1/7 of a hospital's costs, according to a study in the Journal of the American Medical Association. Another study published in Health Affairs in 2014 found that administrative costs accounted for 25.3% of all hospital costs in the U.S. health system. If anything, that number is higher today. In principle, Medicare could use its extensive bargaining power to cut hospital charges, but Medicare is very timid about challenging hospital billing practices and is reluctant even to crack down on the notorious abuse of upcoding, quote unquote, assigning the most expensive reimbursement code possible to every patient condition. If I once had, say, benign heart palpitations, and I go to the hospital for knee surgery, the hospital would assign a code allowing it to bill at a higher rate on the premise that I'm also a heart patient. So Medicare could save taxpayers a lot of money. Why are they so timid? Because hospitals in many areas are the largest and most politically powerful local employers, even more so when they are teaching hospitals connected to universities. Don Berwick, who headed the Centers for Medicare and Medicaid Services under President Obama, told me, if CMS ever tried to seriously crack down, their phone would ring from the American Hospital Association, local senators and congressmen, and the White House. One of the many regulatory failures of antitrust in the U.S. is the nearly complete failure to challenge hospital mergers and acquisitions, which have created monopoly power and degraded services in city after city. When the FTC has tried to move, it has been overruled by conservative courts. Even worse, many of these merger binges are by hospital systems that are nominal nonprofits such as Mass General, Brigham in Boston, and the University of Pittsburgh Medical Center. In New York, Mount Sinai is now an 8-hospital system. In Philadelphia, the courts overruled an effort by the Federal Trade Commission to block a merger of 2 nominally nonprofit systems, Thomas Jefferson University and Albert Einstein Healthcare Network. I thought the Albert Einstein Healthcare Network originated at the Albert Einstein Hospital in New York. Going on with the article, which together now control 18 hospitals and at least 60% of inpatient services. According to a study published in Health Affairs, 7 of the 10 most profitable hospitals in the United States are technically non-for-profits. Hospitals also overuse specialists who can bill at higher rates. Back in the day, if you had, say, a small wart, your family doctor would remove it. Today, you're likely to be referred to the dermatologist for anything more complex than a hangnail. And of course, the dermatologist can bill at a much higher rate, some of which is shared with the hospital as profit. But here's the irony. This general business strategy is backfiring, not only on patients, but on hospitals. Most large hospitals today are losing money. They have overspent on capital equipment and lavish facilities and acquisition of doctors' practices to attract patients for the most lucratively reimbursable procedures that add costs and leaves less money for basic care. Boston is now suffering from an emergency room catastrophe. This is no longer about COVID. There are few such cases in the ERs. The Boston Globe recently reported standard 8-hour waits in the emergency rooms at Mass General. People were piled up on gurneys in hallways. It is unprecedented in my career, Dr. Michael Van Rooyen, Chief of Emergency Medicine at Mass General Brigham, told the Globe, adding that about 6% of people who sought treatment in the ER gave up and went home without being seen. The ER pileup is fundamentally the result of staff shortages. RNs have burned out from hellish working conditions, and many have left the profession. This is another vicious downward spiral. If there were more adequate staffing levels and better pay, there would be less burnout from nurses. But hospitals spend so much time on acquisitions and facilities for the most lucrative procedures that they can't find enough money for basic clinical staffing. And because of the political power of hospitals, nurse staffing ratios are one more fundamental that is unregulated or unenforced in most states. When Mass General, Boston's oldest and most distinguished hospital, entered into a joint operating agreement with the Brigham and Women's Hospital in 1994, the new parent corporation was named Partners Healthcare. It later occurred to the corporate leadership that this bland branding was squandering one of Boston's most familiar and prestigious brands, the Mass General Hospital. Okay, and Brigham was also right up there. So in the contest for market share, the execs at Partners decided in 2019 to take their branding full circle. They spent a cool $100 million on a campaign to rebrand Partners as, wait for it, Mass General Brigham. Sheer genius. Just imagine if some of that had been spent on nurses or emergency rooms. The executive pay is also exorbitant. Ann Klebanski, chief executive of Mass General Brigham, earned $4.3 million in total compensation in 2020, the most recent year for which IRS tax forms are available. Her predecessor, David Torchiana, took home $6,128,085 in 2019. 9 executives received more than $1 million. I know the cost of living in Boston is very high, but it ain't that high. Despite its nonprofit status, which generates massive tax breaks, Mass General Brigham does not deign to publish annual reports disclosing the salary information or details of its relative outlays and capital investments. It does disclose its quarterly profit or loss. You could actually get a lot more information from mandatory SEC filings if it were a for-profit, which it is in everything but name and legal form. There was a time before the allure of market competition and profit maximizing took over, when hospitals were more heavily regulated. 2 basic mechanisms that prevented the game of padding bills were direct rate by regulation and certificates of need. Until the 1980s, in most states, hospital rates were directly regulated, a system known as all-payer rate setting. They still are in Maryland, whose costs are far below average, but rate regulation was phased out in most places in favor of market competition, which of course works nowhere near as well as rate regulation, at least not when the industry is full of concentration. In that era, most states and the federal government also required significant certificates of need, quote unquote, before hospitals could buy expensive new equipment that might duplicate equipment available elsewhere in the service area. In the area of deregulation, certificate of need regulation was also scrapped or weakened, leaving hospitals free to purchase even redundant capital equipment that adds to the rate base. In fact, certificates of need have now become a barrier to entry for startup hospitals, which have to navigate the regulatory thicket to get cleared to buy equipment, while dominant rivals who have mastered the system skate by. A variety of market-friendly techniques were devised to contain costs. Hospitals proved expert at gaming all of them. The most highly touted was called DRGs, or diagnosis-related groups. The idea was that the insurer would pay the hospital a flat sum based on the average cost of treating a given condition rather than paying by the day or by the suture. This way, the hospital would be incentivized to use the most efficient, transparent modalities rather than the most lucrative. Dream on. The concept was first devised by researchers at Yale in the early 1970s. New Jersey was the first state to implement a version of it, and in the 1983 budget legislation, DRGs were mandated for Medicare. How did that reform work out? In 1983, healthcare accounted for just under 10% of GDP in the United States. Today, it is almost 20%. The hospital's response to DRG was more corrupt upcoding. One Boston area hospital offers physicians incentive payments of up to $41,000 a year for upcoding. Here is a handy chart based on materials sent by the hospital to doctors explaining how the incentives work. And in parenthesis, thanks to doctors David Himmelstein and Steffi Woolhandler. Those two have been more trouble for the insurance industry and the politicians than any other two doctors in existence. They work together most of the time. They write huge numbers of articles. They expose the costs in the insurance industry. Upgrading bonuses for PCPs at a Boston area hospital up to $41,000 per year. PCPs are primary care physicians, of course. How does it work? The metric for the program is the diagnosis recapture rates for patients in your panel and covering patients not in your panel that you see and treat. The incentive payout plan for primary care is as follows. Physicians whose panel recapture rate ends 2022 at or above 80% will earn $13,000 plus $14,00 for every percentage point above 80% during the base period times your clinical full-time equivalent, CFTE. A physician whose coding recapture rate is below 80% for their panel, who improved this rate over baseline from the prior year by a minimum of 10 percentage points to at least 70%, will earn $6,700 times your clinical full-time equivalent. Until recently, advocates of single-payer healthcare have focused on comprehensive coverage, but less so on the abuses of profit maximizing medicine. If we went to Medicare for all but did not reform these billing practices and did not end the system of profit maximizing medicine entirely, these excess costs would simply be piled onto taxpayers. As a representative from Miller Jayapal's current Medicare for all bill does best at addressing these abuses, and Bernie Sanders' latest version is more attuned to them than his earlier bills. On the Jayapal's bill, co-sponsored by about half the House Democratic caucus, the bill would keep some elements of fee-for-service medicine and diagnosis-related coding, but hospitals would operate under global budgets. That is, they would receive an annual flat sum from the government that would be adjusted regularly to reflect caseloads. Medical education, one of the ways that teaching hospitals paid bills, would be its own separate budget item. Capital outlays and staffing ratios would be regulated. Incentive compensation aimed at gaming the system would be prohibited. There would be much greater emphasis on primary care. This legislation, which merely reflects the common practices in most of the European nations, is at the outer fringe of what is even debated in the United States. It is a reminder how inefficient as well as unjust is market-led medicine and how incremental reforms can never repair our broken health system. So I thought that was a pretty illuminating and pretty cool article by Kuttner. Well worth our time to go over. Uh, okay, to me, whenever I get into the details of the healthcare system, I find it shocking. I find it very ruinous, and I find it uh, completely lacking in integrity or concern for patients or concern for the government or concern uh, of any kind for how you ought to be running a business, whether a profit making business or a nonprofit. So, okay, other comments? Steve Wolbrand says, was it just you and Bonnie? Yes. It was just the two of us. That was one reason why it was all so nice. Steve says, hi again, D. Steve says, please hit the like button. Thank you, Steve. Steve says, even with insurance, you're going to get crazy bills. Yeah, we do. We usually don't get crazy bills from Kaiser. It's strange. The bills are very detailed, but it turns out they pay everything they should pay. They seem to be very meticulous about this. Kay says we need single payer for sure. Yes, we do. Steve says I have Blue Shield. It's not too bad. Steve says, Dot, I invested heavily in high risk developing countries in the Norths. He said, I tripled every year. Okay, I'm good for life. Steve, I'm so glad it worked out for you. Steve says, I'm going to have to see. 1209. Steve says, I'm going to have to switch over to Medicare soon. Okay, it's very confusing. Yeah, I can't say anything about Kaiser in California. My daughter has, I believe, okay, it's United Healthcare. She works for a subsidiary of theirs, and so I think she's kind of constrained, okay, to that. I don't think she's had to take um, too much advantage of it. Kay says, wouldn't be that way if not for all these Part C's. Yeah, yeah, Medicare Advantage. And Steve says, Gus, hi. Who's Gus? Steve says, Fauci lied about everything. It looks like we have a new troll. Steve says, don't get sick in the USA. Which of course reminded me of Alan Grayson's Republican health plan. He used to say, the Republicans have a health plan. It is, don't get sick, but if you do, then die quickly. And on that note, I think I'm going to say goodbye for now. In not too long a time, I will have a second stream coming up here.